Welcome to the Pod of Inquiry, pushing the envelope for human understanding and optimization, the podcast for podiatrists. The Pod of Inquiry is designed to empower you with knowledge. What happens from there is up to you. Your host, Dr. Stephen Barrett, has designed this show to take you down some very deep rabbit holes, hopefully bringing you back out again, relatively unscathed, but cerebrally whipped, enabling a better understanding of all things worthy of inquiry. If you have more questions after the show, then that is good. The new discovery today many times was the new discovery 50 years ago, only to be suppressed or plainly ignored. Medicine and surgery can sometimes take a long while to get their paradigm shifted. We hope to have a lot of fun on this show and maybe destroy some ridiculous dogma along the journey. Thanks for joining the show today. Let's start spelunking.
So today's guest is my nerve fellow, Dr. Artinder Nagra, and I'm having her back again this week because we're going to talk about something that I think is revolutionary and will add so much value to your practice, as well as maybe overcoming some very significant adversity for your patients who've been told that they just have to continue to live with that drop foot. We're going to talk about a diagnostic lidocaine block that we named the Phoenix sign that you can implement in your practice, and this will help you differentiate whether or not it is really coming from the central nervous system versus a peripheral nerve entrapment. I hope you enjoy this episode, and I've kind of described it as my gift to you all, because when you get this thing and you utilize it, you will be blown away, and patients will absolutely just start crying in your exam room, not from sadness, but happiness that you were able to figure out something that no one else could. Without any further introduction, please enjoy this conversation that I have with my nerve fellow, Dr. Artinder Nagra, about the Phoenix sign. I'd like to welcome you all to the Pod of Inquiry. I've got Dr. Artinder Nagra with me, who is my nerve fellow, and we're going to talk about a little gift that we hope to give everybody for improving their clinical diagnostic abilities, and it's called the Phoenix sign. Thanks, Dr. Nagra, for joining me today.
Thank you for having me. It's always a pleasure to be here.
Yeah. So you've seen a few Phoenix sign blocks, infiltrations, whatever we'd like to call them. What was your first impression when you first saw it?
I was under the impression that a block has more of just a numbing effect. I actually was very pleasantly surprised to learn that a small amount of a block can do so much more. I think when we think about local anesthetic blocks like lidocaine or marcaine, you don't realize the other properties that they possess. And so my first reaction was just of disbelief in that. I was just so surprised to see how much function a little bit of local anesthetic could give back to a patient.
Oh, it's incredible. I still get chills every time I see it, and I've seen it hundreds of times, if not more. And I think it's astounding to patients that they've had this drop foot or significant weakness in their lower extremity, and no one's been able to tell them what's going on. And you give them a couple of tenths of a cc of lidocaine, then all of a sudden they get function, sometimes full function, as you've seen in the clinic. So let's talk a little bit about this. So first of all, I think this is a very powerful gift for not only our physician listeners, but also for the patients that they will see, because so many times these folks have a true entrapment of the common perineal nerve at the fibular neck, or let's call it the common fibular nerve to make the anatomists a little happier. But the point is that a lot of these patients are told, after a hip surgery or back surgery or knee replacement, different types of things, that, there's nothing that can be done for you. We don't know, it's coming from your back. Or we've even seen a couple of stroke patients that were told that, it was coming from their back. And when you administer this block, all of a sudden they have function. So you know that they certainly have some type of a peripheral entrapment. So I think this is a very powerful gift for not only the clinician, but the clinician's patients. So I'm excited to present this today. So we named this after observing this back in 2017, the Phoenix sign. A lot of people said, well, why do you name it the Phoenix sign? Is that because you were from Phoenix? And the answer was, well, no, it was because of the mythical bird that arose from the ashes after it was presumed to be dead. And that's really what we perceived, that once you had these drop foot cases, that's what it was, and there's nothing that could be done about it. So why is this so important? Well, I think that many patients are frankly living with a condition that they really don't have to live with. And we know that nerves can be entrapped in a couple of places at the same time, the double crush phenomena. You and I have talked about Upton and McComas just last week, I believe. And
yes,
it goes back to, what was I right on the date, 1973?
I believe so, yeah.
Okay.
Yeah,
I don't know why. Go ahead.
I was going to say I was between 63 and 73, but you might be right.
Yeah, that sounds like me. But yeah, so anyhow, these folks can have compression in more than one area, or even a CNS manifestation. Like I mentioned just a little earlier about, that we've had a couple of stroke patients that we're just curious about to see, what their definitive cause of their drop foot was. And it's always presumed that once they have a stroke, that's it. It's caused from a bleed in the brain, and there's nothing that you can do about it. But sometimes when people have a stroke, they fall and they twist their leg or their ankle, and they end up actually with a common peroneal nerve injury. So by, implementing this diagnostic technique, there are, and let me preface everything, stroke patients, more often than not, it's a central manifestation. It's CNS 100%. But there are a subset of patients that we've seen that actually hurt their nerve when they fell from their stroke, or when they were laying in bed in the hospital, the leg was laying against the railing of the bed and caused a compression at the site of the common peroneal nerve. So it is a very powerful diagnostic test. And if the test shows that the patient can increase their dorsiflexion by, administering, between 1/10 and 5/10 of a cc of lidocaine peripherally, it pretty much rules out that it's all coming from the back or the CNS. So it's pretty interesting and very powerful. So we first observed this in 2017 and actually stumbled upon it accidentally. The fellow that I had as a nerve fellow then, Wash D. Nasir, came into me and he said, listen, he said, you asked me to give this lady a block because she came in with a lot of pain, and she had had a drop foot for 5 years. And he came in after giving her, I think it was about a half a cc of just plain lidocaine. And he said, listen, you got to see this because she's able to move her foot. I said, no, she's had a drop foot for 5 years. That's not possible. But sure enough, I went into the room, looked at the ultrasound, as we can see in this picture here. Small amount of infiltrate was put in, and sure enough, Rosaline could move her foot. And after 5 years, she had not ever moved her foot again. She had complete paralysis, a palsy of the common peroneal nerve. We subsequently tried to hypothesize why this was happening, and I interestingly said I thought it was due to the vasodilation, and some of my colleagues felt that it was more of a interruption of some type of an arc reflex with the CNS to the peripheral nerve system, and some very exotic theories. So we took this same patient, who was very kind and came back the following week, and we reproduced the first finding, and sure enough, she did get very good dorsiflexion. And then I asked her back again the following week, and infiltrated lidocaine with epinephrine. And she did get a little bit of effect, but not nearly the effect that she had with just the lidocaine without epinephrine. So I felt that it was a vasodilation phenomena, and we'll talk a little bit more about this in the study that we're doing with the papaverine, but I don't want to jump to that just yet. So this picture shows what happens when we do a peripheral nerve decompression. Routinely, we see this, and you can see on the left side of the screen where it says 9 minutes or 9:08 that it's quite tight. You can't see the vasa nivorum, and then you can see that the nerve has been decompressed in the right side of the picture. You can see that there is a little hourglass deformity, as we see right here. And now you can see this vasa nivorum coming in right here that we didn't see over here while the nerve was still very compressed with multiple bands of, connective tissue over the nerve. You can see right here, there's like a band. It's almost like a dental floss that's across that. You can see a little bit of vasa nivorum here. So we knew that we would get almost immediate improvement in blood flow after nerve decompression. And we actually did an intraoperative study with EMGs, intraoperative EMGs, and we would see just astronomical increases in motor function right after the nerve was decompressed. Well, you know that nothing has gone on from a reestablishment of the motor end plate connection or anything like that in a matter of minutes. And the only thing it could be is the blood flow. So this paired up very well with what we saw in the clinic with the diagnostic block as far as being a vasodilatory phenomena. So if you look in the literature, you can see that pretty much all local anesthetics except one, you know which one that is, right?
Oh, yes, cocaine. Yes.
Right. I know.
I'm thinking in the local anesthetic world,
no.
but yes.
Well, but cocaine is a local anesthetic, right?
Yeah.
And the ear, nose, and throat surgeons still
utilize it in the nose.
Yeah, because it causes vasoconstriction, so they get that benefit, so they don't get so much bleeding. But anyhow, well, if we look at this chart, you can see that really bupivacaine has a much stronger vasodilatation than lidocaine. But come over here in this column and look at 1 minute where they measured the mean percentage increase in the femoral artery blood flow in dogs after an intraarterial injection. So at 1 minute, look at what's happening. They're getting, and lidocaine is kind of one of the weak sisters in here. We probably would see a greater response if we use bupivacaine, but it's a little more uncomfortable to inject, so that's why we stuck with the lidocaine. But between 1 minute and 5 minutes, it drops pretty significantly, and this correlates with what we see clinically, right? Because we see usually 2 to 3 minutes, 4 minutes, and then by 10 minutes, the effect seems to be gone. So this led to the question, what's really causing this, right? And so you and I have been involved with this, and we're getting ready to submit this for publication. But we use papaverine, which is a very well-known vasodilating drug, been used in vascular surgery for decades. And so what we found was that there really was no difference whether we put in papaverine or lidocaine. And so that really, nothing's 100%, nothing proves anything, but this strongly suggests that what we're dealing with is really a vasodilation effect. And then when you look at what we did with several patients with lidocaine with epinephrine, it's pretty suggestive that this is why we're seeing what they're seeing. So not only does it definitively diagnose a common perineal nerve entrapment, and this is being applied to other nerves in the lower extremity, not just the common fibular nerve, but that's what we're going to talk about today only. But I think another year from now or 2 years from now, you might see more data coming out with tibial nerve blocks and improvement in motor function, these types of things. But so we published this back in 2020, and it was a very interesting study, because what we wanted to do is not only did we want to see how well the Phoenix sign was from diagnostic standpoint, but we also wanted to see, could it give us any prognostic information? Could it be our crystal ball, so to speak, and say, all right, if the patient has a positive Phoenix sign, what's the outcome if we decompress that peripheral nerve? And what we found was that there were 26 patients tested, and one of them out of the 26 had no improvement with the diagnostic block, and subsequently, after nerve decompression, had no improvement in dorsiflexion. So the 25 patients who did have a positive Phoenix sign and then underwent nerve decompression, all 25 of them showed an increase in dorsiflexion strength of the extensor hallucis longus after nerve decompression. So this actually is a crystal ball, and we're working on another study now that will be, I think, very additive to the data in this study and support this even more. So it's a very powerful diagnostic tool, and I'm pretty excited about it.
I'm sorry to interrupt, but before you continue with this great conversation, we need to take a quick break to acknowledge this week's sponsor.
This episode is sponsored by Zuckerman Future Technologies. Their REMI laser is a Class 4 laser for professionals. It is different from anything available on the market in that it is a lightweight, 4 pounds, and compact but powerful device. Its large touchscreen makes it easy to use, and it has multiple wavelengths of 650, 810, and 980 nanometers, power variables up to 30 watts, and a safety rating that make it optimal for many conditions. With the REMI laser, you can give your patients effective, pain-free treatment of soft tissue issues. It is ideal for treating plantar fasciitis, fasciopathy, Achilles tendinopathy, peripheral neuropathy, neuromas, arthritis, onychomycosis, warts, and more. It is the only laser with FDA 510(k) approval and insurance coverage. Zuckerman Future Technology deals with all aspects of the REMI in-house, and this keeps out the middleman, which allows them to offer this revolutionary device at a 40% reduced price compared to anything that can provide the similar results. There are currently over 700 REMI lasers being used in the USA and Europe, and those numbers are rising every day. Learn more about this fantastic product and join the growing number of professionals who are benefiting from having the REMI in their practice. I personally implemented the REMI into my practice about 4 years ago, and I cannot say enough about the utility, versatility, and efficacy that I have seen with this technology. I can also say that of all the capital equipment that I have purchased, and it has been a lot over the last 36 years, this is one of the best expenditures I have made. Zuckerman Future Technologies is offering the listeners of the Pod of Inquiry a really great deal. You'll get a $1,000 cart for the REMI laser when you use code 007. That's right, a $1,000 cart for the REMI laser, just for bona fide Pod of Inquiry spelunkers. You can go to the website, remilaser.com, plug in your James Bond code of 007, and get your free cart with a purchase of the REMI.
Just a question I have. So let's say they have a positive Phoenix sign, and you know that because of the vasodilation, that nerve is getting more blood supply, more nutrients, even though it's pinched, the vasodilatory effect allows it to function better. And so that person will do very well with the nerve decompression. But what if they don't have a positive Phoenix sign? Does that mean they will not do as well with the decompression? Is it still worth doing it?
Well, that's a great question. And I think what we're seeing now clinically, in addition to this data here that we're showing, is that if they don't have a positive Phoenix sign, the likelihood of them gaining function back is probably not great. But there are other considerations with these patients. Some have incredible amounts of pain and loss of sensation, and those patients may regain some sensory component, and many of them gain a very substantive decrease or elimination of the pain that they've had. So there still is a case sometimes when they may have a negative finding with a Phoenix sign block to go ahead and do a nerve decompression for the patient. But you have to factor that in clinically. And this is one more tool, one more diagnostic bullet in the box, so to speak, to help you figure out these problems. But there's still indications, and some patients are just so desperate they're willing to try it. And we've seen in the OR just over the last few months, some people that had this kind of a scenario. They did not have a positive Phoenix sign, and we did intraoperative nerve EMGs, nerve monitoring, and they didn't show much at all. And then some of them down the line actually gained some function, which was pretty extraordinary. So,
right,
the human can overcome some pretty adverse conditions. But generally speaking, I think it gives you a pretty good idea that if you're going to see a positive result after the nerve decompression, you want to see a positive result after the nerve block. And but
right,
even though this is a tremendously beneficial diagnostic procedure, it's not the 100% definitive, like, okay, you didn't get a positive effect, you're not a candidate for surgery, because there are, like I said, other considerations that have to go on with this. But
right.
yeah,
Right.
So anyhow, and it's not an easy block to perform, because you're doing it under ultrasound guidance and positioning. I think you found that it looked a lot easier until you started doing them, right? And it took
Absolutely. I think there's a lot of, there can be user error. So it's good to practice seeing what nerves look like under ultrasound. Yes, I can speak from experience. Whenever I saw you do the block, it seemed very, very simple. But when you're doing it yourself, you have to be very cognizant of and aware that is this the nerve and not the fascia. You have to be aware of the anatomy in the area, and it just requires experience of looking at nerves under ultrasound. Of course, I think having a decent ultrasound machine helps, and so it's definitely good practice. And so I would recommend that you try to, if you're ultrasound naive, definitely have some practice trials before trying to do this, because it can be difficult. And then that brings me to another point: is the physicians who are not used to doing the Phoenix sign, how do they determine their patient would be a good candidate to do the Phoenix sign block on? Because it doesn't necessarily per se have to be for foot drop. It's indicated for somebody with a foot drop, but there are other patients, I believe, that we've seen sometimes in their history, they'll talk about feeling weak and maybe complaining of falling, correct?
Right. Yeah, so no, that's a good point that you bring up, Dr. Nagra, because many of these patients will have motor strength, and they really don't even know that they have a weakness until you examine them. And they're, wow, I didn't realize I was that weak. It's very insidious, right? But they will say, we just had a patient this morning that was talking about how he was falling a lot because he trips on his toes, can't pull his foot up, but never really got to the point where it was just a frank drop foot. And then you'll have people that'll come in, they still have continued pain after an ankle sprain, and they've tweaked their common peroneal nerve or their superficial peroneal nerve farther distally at the foraminal level, and you give them a block and their pain gets much, much better. And people will say that brings up another point. People will say, well, yeah, their pain's going to get better because you blocked them with a local anesthetic. But the answer is no. They were given a sub-anesthetic dose, and many of them, as we've seen, actually have an increase in sensation, which is so counterintuitive. But because of that dosage. And that's where the papaverin could play a little bit better of a role, maybe from a pure academic standpoint. It's like, okay, let's see what happens. The patient comes in with pain and you give them a little papaverin and all of a sudden they have more blood flow to that nerve that's entrapped. Well, their pain goes away. You can't attribute that to a local anesthetic effect. And so I think it's, a very useful diagnostic parameter for people that don't have a drop foot but do have definite common peroneal nerve or common fibular nerve entrapment.
Right. And I think it's very important to emphasize that aspect, because I've seen you give it just 0.2 or 0.3 of a cc, as you mentioned, which is not a lot.
Right.
So it is a subtherapeutic dose, and patients are always in disbelief when they see it, because most of the time you can compare to their other leg, and one leg they'll have really strong, let's say extensor hallucis longus function, and in the other one it's less than half, and they don't even realize how weak one extremity is until you give this block, and then immediately, 3 to 4 minutes later, they now can show from a 2 out of 5 or a 3 out of 5 muscle strength to a 5 out of 5, and they're really, really pleasantly surprised. And along with function, you're absolutely correct. I've seen them personally say they've got a lot of sensation back. Some of them can't feel their foot, and then we administer this block and they feel it. We just had a patient, I think we did surgery on Monday, where he falls in the category of those patients that how much function he gets back, only time will tell. But I did the Phoenix block on him just as a diagnostic, but you wouldn't believe, rather than function, how much sensation he achieved.
Right.
So it's even diagnostic in that aspect, that even if we can't give him the function back right away, it's a good predictor of how much sensation they'll get back. And he was able to walk better, not because of the muscle strength, but just purely because he could just feel his spatial awareness. He was more aware of his surroundings because of the sensation in his foot.
Right. That's very interesting. And the other thing that we've not talked about, but that you and I have both seen many, many cases, and we need to do some further research on this, is the effect on the perfusion. Because we've seen people that have no dorsalis pedis artery whatsoever, and then after administration of a couple of tenths of a cc of lidocaine up by their common peroneal nerve at the fibular neck, all of a sudden now we're able to measure a waveform in that dorsalis pedis with the Doppler. And that is pretty incredible. I think that has some more ramifications for maybe in the future it's something that could help the endovascular guys, because if you're able to open up an artery temporarily while they're trying to do something really distally, that could be an application. It's too early to say, because we've really been just looking at how accurate is this from a diagnostic standpoint for foot drop, but there are these other homeostatic improvements that we see in the lower extremity. And interestingly, we see the same things after nerve decompression, but on a long-term basis. So that's another project there in and of itself. But yeah, it's pretty astounding, isn't it, though, when you see this? Every time I see it, it's like, the patients are just blown away by it. And
another thing, it's nice for the patients in real time to see what's happening. Sometimes you explain what a decompression, how it can help, but to do something like this, a diagnostic block that improves their function in real time or improves their sensation in real time, is really convincing for them, because it's not just a hypothesis, it's something they can actually see and feel.
Right. Well, anything more you have to say about the Phoenix sign? I know this is the little gift that we want to give all the clinicians. I think if they start implementing this, it's going to be big for them in their practice. And it's one of those things where the patient feedback, it's such a beautiful thing to get that karma, and that, they've been told there's nothing that can be done. Or it's coming from my back, and all of a sudden, 5 minutes after you give them a block, they know that's all BS, and that there is something that can be done for them. And that's pretty powerful. Yeah.
And I think the more people, as we do this block more and more, we get different types of patients all the time. And every, different subset of patients teaches us something new about this block. And I think that more and more people start applying it, they might learn something different than us. So it's about one of those things is where it's a new technique, but I think it has ability to showcase even more new things. It can maybe, like you mentioned, a homeostatic mechanism. We learned about that the vasodilatory effect can improve function, but we're learning it can improve sensation. So I think the more people that can practice this, they're going to see a different subset of patients than we are. And maybe those patients have something new to teach us. So I think it's a very beneficial, real-time, something that you can show patients that this is why I think you would benefit from this. I think diagnostic blocks in general for nerves do that. When you give a diagnostic block for a nerve and it relieves the pain, that's very beneficial and factual for the patient. But when you see not just the pain go away, but improve of function, you get that muscle strength back. Patients, like you said, they're in complete disbelief that their nerve was even injured, and they didn't think it was possible. And another thing I think it's good to mention is that a lot of the times these patients will come in very generalized pain and muscle weakness. And so sometimes it's hard to pinpoint to which nerve, do you start? And I think it's always good to start with the common peroneal nerve, if that is the case, if it's very generalized, because a lot of these patients haven't had access to a peripheral nerve physician. And so when they're seeing us, a lot of them have had this aggravated condition for years. And so it's very generalized. And the common peroneal nerve seems to be very good at telling us where to start. Right.
Well, there's another factor too. Jim Anderson has published some nice work on restless leg syndrome, where common peroneal nerve entrapment can be the, pathoetiogenesis of that condition, in conjunction with other things or solely. And I can't tell you how many patients have come back to us over the years after we've done a common peroneal nerve decompression, and they'll say, my restless legs are gone. Or their wife will say, hey, he stopped, having restless leg syndrome, So, so that's another condition aside from the balance. So there's a lot of stuff that's going in, from a clinical standpoint, with this condition of, entrapment of the common fibular or common peroneal nerve. Now, I'm kind of excited to announce today that in March, we will be ramping up our educational activities, where a lot of people have reached out and want to come for a diagnostic nerve block and ultrasound of peripheral nerves and how to do these blocks. And so in March, we'll be offering our first course, and people will be able to come into Marietta and spend a day with us and learn how to do these blocks and how empowering they really are. And we're probably going to also do a little section on peptides for management of musculoskeletal disorders at the same time. So you can get that information over at our website, potofinquiry.com, and get signed up for that course. So we're looking forward to having you down. Well, Dr. Nagra, thank you very much. And I appreciate you taking time out of your clinical day today to hang out with us and share this knowledge. I think it's going to help a lot of people.
Thank you. I'm thankful to have learned about the Phoenix sign from you. I think the very first time I saw it, I was one of those patients in disbelief. I thought this can't be real. And then I realized, no, wait, there's a published article on it. So
yeah, well, I mean, you can have stuff that's published, but when you see it with your own eyes and that patient starts to tear up in the room because they haven't been able to do that for years, it's a pretty chilling thing. And it's something that, I've taken up now. This is one of my missions. I have to get this this diagnostic technique out there more, so these folks aren't just written off, because we know that there's a lot that can be done for them. So, oh, very cool. All right. Well, I appreciate you and love working with you. And let's have some fun in 2023.
That's right. Thank you so much. Always a pleasure.
Bye-bye.
We hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes, found at our website, podofinquiry.com. If this incredible and educational conversation has tickled just a little bit of your cortex, please leave us a review and spread the message to your friends and colleagues. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find this a welcome goblet to sip from, or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pod of Inquiry disclaims any responsibility from anything taken from the show and used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.